been our partners, and they have come forward in not only organizing this event and participating, but supporting in the activities of PANAH in all walks of life previously and nowadays. We also have collaborations from, apart from the Health Services Academy that I mentioned, Bakai Institute of Diabetes and Endocrinology, Karachi, Pakistan Association of Family Physicians, Dr. Manzoor is sitting here, and who will propagate these message into the grassroots. And we have a important contribution from Zohra Institute of Medical Sciences. So this is all about the overview of the program. Now let's have some crude discussion. I'm afraid the overview of NCD begins with some very sorry figures. We all know it's a big burden. We all know we have our kids and kin suffering from these things, and it's very late by that time. The assembly today and the effort of organizations like PANAH is based to create networking and liaison among the public health professionals as well as clinicians to try to stem this tide by stopping it at the level of primary prevention or primordial prevention. Of course, you all know that the non-communicable diseases encompass a wide array of diseasing, starting from cardiovascular disease, diabetes, hypertension, hyperlipidemia, obesity, metabesity, and there is another spectrum of non-metabolic, non-communicable diseases, most important amongst which is mental health, injuries and accidents. But that's not amongst the purview of the discussion of these 2 days because they require a separate forum for that. I don't think I'll go into details of definitions and all that, but I'll just highlight the numbers. 51 million hypertensives, 10 to 20. This diabetic figure is this. We have a very eminent researcher in the form of Dr. Yaqub Ahmedani and Basat Ali from Bakai, who have come up with a survey from Balochistan and Sindh, and that has just changed the numbers. Where we had about 10 million, we have now about 30 million. About 25% of Pakistan's population is affected by this. Of course, ischemic heart disease, we always see stroke, cancer, but cancer and mental health we'll deal with in a separate session soon. The burden of NCDs. So far as Pakistan is concerned, there are first 2 figures which I would like to really highlight. That I would not say there is lack of, but the efforts are disjointed. The efforts and awareness are disjointed, and they need to be integrated. We also need a much more robust political will, but more importantly, that I would like to mention over here is this lack of reliable data. Reliable scientific data in public health sphere needs to be collected, collated, analyzed, and reevaluated. And it's on the basis of this data that will make policies and public health interventions that are required. And recently we have had a wave of COVID-19, which has really put the focus again on the communicable diseases, non-communicable. Communicable diseases just igniting the minefield of the non-communicable diseases. So this is a big, so we need to act. And we need to act because it's not only that the burden of disease is high, which I just alluded to. We have some non-communicable diseases, about half of the burden of disease. But when it comes to deaths, the non-communicable diseases increase to 60% in deaths. And when it comes to disability affected life years, then the non-communicable diseases impact jumps even more to 72.5%. So it's that just not that we have a very high burden of disease, we have a burden which affects the health economics of the whole thing. And as you can see, the top 10, even in the maternal and neonatal childhood, the cause of death is cardiovascular disease. So, and they are just creeping up and up. So we must do something to stem this rot. And as you can see, this I just wanted to highlight the jump in diabetes that we have seen in numbers. And it may go even further if we do not institute the measures at the level of community, like prevention of obesity, the sugary drinks, the smoking, and so on. This is very important for the planners, and I will just briefly touch on that. And my highlight is that out of 279,000 million rupees which we spend on health, just 755 in Punjab, 200 million. 200 million is paltry sum. This is no money. And unless we invest in the health of our future generation, this money is going into our health, in treating the sick. And this money is for health of our future generations. It's here that we need to put our focus, energy, and finances. Similarly, it's just from where this money is coming. You see, there is government spending fairly about $25 of the 100, but majority of money is out of pocket. This is going to increase in future. We are not seeing the contribution of the society, of the NGOs, of the government coming in. It will be on the individual. And that's why we hope that the interventions like Sehat Insaf Card and other things are going to change things. But these projections are based a couple of years ago. And let's see that if we can bring this green bar lower out of the total health expenses. And what will bring this green bar lower is the political commitment, which I hope is now increasing, but more importantly, the cross-sectoral partnerships. It's here that the organizations like PANAH and the policymakers need to get together. Of course, we would need to have a financing model and incorporate technology into advocacy, because as we have seen in our SRS program, in our other programs, the technology is bringing in those who are marginalized, those who are at the lower ebbs of the society, into the mainstream, into the areas where delivery is taking place. And I think we need to invest in that. Next, why PANAH? One, we wanted to. PANAH has a track record in health education and advocacy. We already, couple of years ago, just before the onset of COVID, Ma'am Samra Mazhar is privy to this. PANAH has, on the directions of President of the Islamic Republic of Pakistan, who is Patron-in-Chief of PANAH, involving the stakeholders like Health Minister, Parliamentary Secretary, the DG Health, the NCD Control Program, we instituted a President's Public Health Initiative. And this type of initiative, which I'll allude to briefly, needs to be appraised. We need to do the course corrections, and we need to find out the mechanisms for better outcomes. And the onus is on us, the academia, the policymakers, and the research organizations like Pakistan Science Foundation and Pakistan Health Research Council, which should provide a common platform to all these classes of people to come together and do some good for the country. I would not go into details because it's a very exhaustive document, the PANAH proposed President's Preventive Health Initiative, but it's broadly in line with the national control program for NCDs that we already have in place. We need to have more input, but the wish was to create a platform for expert advisors who come from professional bodies, and they give specific committees to develop specific advisory guidelines and delivery pathways to achieve the objectives of the NCD control program. Of course, capacity building, specific training of the healthcare services is important. And PANAH and its professional partners pledge to help in advocacy campaigns in addition to the media content creation for the program. I am very thankful to the broadcast media, apart from the social media, who are involved in transmitting our message across the globe. And they have come here especially. It's very important that we continue this partnership and increase our scope and extent. Now, I have alluded to Pakistan, but just some global numbers. The problem we thought it's of developed countries, but globally it is becoming a problem of developing countries more as compared to the industrialized societies because they have better healthcare delivery systems. But the numbers are very high, they increase every day, and the figures are the same. But what we see here is just the tip of the iceberg because we just see ischemic heart disease, stroke, and all that. But on the bottom is obesity, physical activity, diet, raised blood sugar, raised blood pressure, so forth. I will just briefly touch upon each one of them because there are some medical students sitting here as well. And we have a large audience who are not as expert in these fields. So they need to be sensitized to what are the risk factors for the non-communicable diseases. This again brings home the same point that the numbers are increasing and ischemic heart disease, stroke are on the top as always. Now, so far as risk factors are concerned, there are some things about which we can't do much. The genetic factors here, we can't do much about race, gender, ethnicity, age, and all that. But there's a lot that we can do as individuals, and there's even more which we can do as society. For example, these days, the environmental factors, and it's good that we have leaders and government who are investing into the health of the nation by investing into a green Pakistan. And I reckon the other segments of the society, including the advocacy partners, they need to increase this bit because this is dependent upon a lot of factors. Self-management, most important of all, it needs commitment, prolonged commitment, and continuation of the lifestyle. Because a lot of people stop quitting tobacco, they restart. Similarly, physical activity, all of us go to gym on New Year's Day or a week or 10 days later, and then something, COVID is something which is persistent, but then something happens. And we need to have a prolonged, continued, sustained commitment to make these factors of self-management. And that's why we have a session on the lifestyle management tomorrow morning. And I will request you to attend that as well. Of course, we need to treat the diseases better. We need to treat the blood pressure at an earlier stage to achieve the targets of effective blood pressure control. We need to have the lower blood sugar cholesterol levels. But these is something that is left to professionals. I think it is this and this which are really important. So this was the summary of what are the risk factors. But it is an interplay of the impact of the smoking affects 3-4 diseases. Each one of the risk factors doesn't cause one disease. This is really important. They are all intertwined. It is such a complex slide, and it is complex for a reason that this interplay of these factors is complex. And we need to just take every risk factor out as far as possible if we want to really have an impact. For example, if you just start physical activity, it will not only decrease your risk of type 2 diabetes, high blood pressure, lipid profile, heart attacks. You may have less arthritis. Certain cancers are associated with obesity. And of course, the musculoskeletal issues like falls, osteoarthritis, and of course, ultimately culminating into early death. So obesity is, I would say, the mother of the apparent mother of all these diseases, and physical activity has to come into play before we institute any pharmacological managements or other measures. As I said, it is associated with a lot of cancers and premature mortality. I have mentioned the obesity already. We'll just go on to hyperlipidemias. This is something which has had a lot of bad press lately. That the Framingham study, as we all know, just put into focus, and there has been then about 5 decades of sustained hammering of cholesterol and all that. recently there has been some data which has put the public into, people come to our clinics and question, Dr. Sahab, cholesterol kam karna hai ya nahi karna? Dr. Sahab, ande khane hai ya nahi khane? So we must tell them that everything has to be put into perspective. But we just cannot tolerate hyperlipidemia. We know that hyperlipidemia, it causes a trauma formation. There are so many other factors like inflammation and stress. They are important, but we need to educate them about the levels of cholesterol, the good cholesterol, bad cholesterol. And then is the most difficult to bring down, the hypertension and the blood pressure. Even in USA, about 60% of the patients do not have adequately controlled blood pressure as to the targets which is specific for their disease and for their age. In our country, the situation is even imperfect. There has been, and the reason for that is that the initial sensitization, like lifestyle measures, like the continuation of medication, like their mental health factors, is not put across as sternly as it should have had. Of course, nutrition is a very important separate subject. The consumption of fruit, vegetables, enough fiber, and less consumption of sugars, carbohydrates, sugary drinks. There is a lot of legislation going on in these in Western countries. Had some success stories in the form of tobacco, but I think our advocacy partners, we are now getting together to get taxes, increased taxes on sugary drinks and beverages. And on this, we have in this inaugural session a very important talk from Dr. Barry Popkins, which I will introduce later. Tobacco use, there are multiple forms that's used in our country because different strata of the society started from betel nuts and leaves and from cigarettes and cigars. It's harmful in every way, and it affects millions of people in causing unnecessary deaths. And this world will be better without Philip Morris Incorporated and so on. But that's the world that we are living in, and we have to deal with it. Alcohol consumption also has a very direct relationship between the risk for cardiovascular diseases, apart from liver diseases. And we think that this is less of a problem in society, but it is there. As I said previously, we just see the tip of the icebergs. We don't scratch beyond the surface. We have to dig deeper, and you would come to know that not only the upper class, not only the lower class, but also the middle class, there is a lot of alcohol consumption and the lot of harmful alcohol consumption, because there have been guidelines on alcohol consumption which are beneficial. But here in our country, because of this is a taboo subject and because of it is an illicit activity, not much comes out in the open. Then we need to see that the salt intake and other actual intakes are according to the WHO guidelines or not. Again, there is no sensitization in this subject. For example, in the primary healthcare setting, we need to educate our patients, not only hypertensive patients, but their family and public at large, to decrease the sodium content. Because the white poison of the 20th century was sugar. The white poison of 21st century is going to be salt. And in our country, there's a very high increased propensity to stroke and peripheral vascular disease, apart from ischemic heart disease and hypertension. So we need to act on that. And then the things that I mentioned initially, the community risk factors like environmental pollution. We have some things going on for air pollution, but we haven't thought much about water pollution. Then there is food adulteration, which is a big, although we have now pure food authorities and things like that, but there are big problems which are persisting. And last and not the least, the stress factors, acute and chronic stresses they cause. Next. Now, what do we need to do? Just 2 or 3 minutes briefly, because the whole conference is dedicated to these measures. You all know what we need to do is to cut the root. not the branches, not treat the diabetes. We have to quit the overweight, smoking, unhealthy, and the social determinants. The WHO, in response to this, is acting since 1956, and then every year in this last decade, there have been new resolutions on different tobacco control, healthy lifestyles, to cancer prevention, and most recently on the prevention and control of non-communicable diseases, which has translated into a plan of action, a global action plan. And Pakistan is a signatory and participant of this. And we have outlined our national action program in the list. But I would especially like to mention to raise the priority accorded to the prevention and control of the non-communicable disease. This is the thing that is the whole crux. Everything comes within this, and we need to strengthen the national capacity, leadership, governance, multi-sectoral partnership, the collaborations, the passing on the message, not only for prevention and control of the NCDs. Of course, there are so many other determinants, but we'll discuss this in detail later. And the paradigm is that we, even before primary and secondary prevention, we should go to the route of primordial prevention and health promotion. This is something that we're doing today. This is something that we should be doing in our families, in our schools, in our mass media campaigns and all that. We need to sensitize people to a healthy lifestyle. And that is what will, and there is a lot of evidence that this strong base needs to a very good outcome at a much less cost. But there are some impediments to our NCD agenda. And when we are assessing ourselves, we must not shy away from pointing out what ails us. Only if we know what ails this nation, we would be able to do some actions. I have always mentioned the political attention and financial support has to remain there. Everything will start, money makes the mayor go. Then there are some areas which initiatives have been taken, like regulation of ready products, but this regulation is weak. We need to give more policy attention to the NCDs. And of course, the individual behavior change is the most important catalyst that needs to start this process. Of course, for coordination, we are all here. And that's why, ladies and gentlemen, I will finish by just summarizing that we do not need to reinvent the wheel. We will just embed the WHO recommendations, our own national action plan, and get things doing. It's just that we need to do things in earnest. We must institutionalize the coordination platforms at both national and provincial levels, because the federal level is just for regulation coordination. The buck stops at the provincial level, where the money is and where the mechanisms and platforms are. And there are some changes which are required in the provincial legislation, especially as regards food, nutrition, environment, and all that. And these need to be done in earnest. It is time that we'll legislate them now so that actions can be taken. Of course, mass media campaigns like this should be a continual process. It should not be a one-off thing and then stops. And not only one organization, it must go across an advocacy coalition. It's just not a single person or single organization's job. We need to increase the liaison and coordination amongst all stakeholders, and that's why we are here. And that's why I ask you, ladies and gentlemen, to please stay in all sessions. Those who have to leave for some reason, they can join in on Zoom. We have our links which will be displayed regularly over here as well. And we have this, we can send by WhatsApp messages for those who are who need to go out and need to come on Zoom. I must thank you, ladies and gentlemen, for a very patient listening. But this is just an introduction to the theme of the conference. We have a recorded talk from Dr. Barry Popkins. He is from University of Carolina, North Carolina at Chapel Hill, USA. He is an eminent figure in advising the governments on the regulation of nutrition and special talk today is on sugar-sweetened beverages. Dr. Barry Popkin is a W.R. Keenan Jr. Distinguished Professor of Nutrition, who was born in 1944 and graduated from Cornell University, University of Wisconsin. He has a PhD in economics, but close to his heart are nutrition epidemiology. And as I mentioned, he has an expertise in advising the governments and the regulatory bodies regarding fiscal policies, nutritional transition, obesity prevention, and sustainability. These are the things which might look like buzzwords to us, but people who have dedicated their lives, they have come up with some very good suggestions. And the topic of today's talk is sugar-sweetened beverages and their impact on NCDs. So can we start Dr. Barry's talk?
Hi, I'm pleased today to present an overview about sugar-sweetened beverage taxes, which is a critical risk factor both noted is one of their top five, but critical risk factor really that both the World Heart Federation and the World Cancer Research Fund have both noted is one of their top priorities is finding ways to cut sugar consumption, particularly taxing sugar-sweetened beverages. I'll begin. This is a brief outline what we'll do. I'll talk about some unique qualities of beverages with sugar in contrast to other sources of sugar in food. I'll talk about the health impact of sugar. I'll talk about the potential for reducing the speed of taxation and some of the health benefits. And I'll also begin by noting now that if you include revenue from that for health or other kind of welfare problems facing the poor, you'll have a really extra benefit. And I'll mention the environmental costs. I'll give from two different countries examples of two different kind of taxes and what I recommend. And then I'll talk about very briefly front of the label package warning labels, which we found to have a really high impact also on sugar beverage consumption. There is a unique aspect of when beverages are consumed in sugar, and I'll talk about it next. And I'm beginning with these two concepts about our biology and then modern day consumption. For the longest time, from the time man was created hundreds of thousands of years ago, we've had a high preference for sweetness. This developed because we needed some of the nutrients from fruit and other products which were sweet, and in contrast to a bitter, which usually were harmful products of various sorts. And the second and much more important is something we really understood over the last 30 years as science looked at this issue. We find that when you drink something, it doesn't affect what you eat. So if you drink water, no impact at all. But when you drink a beverage with sugar added, it increases almost 100% our nutrient intake for the day. Why is that the case? If you understand that we need water or you'll die within 2 or 3 days, but you actually could live for 2 months without food, And then you think about the seasonality of food that was available in our country and in Pakistan, really until the last 40 to 50 years. With that seasonality, when food was available, you wanted to gorge on it, but you needed to keep drinking water. So they separated the two. You didn't want to be drinking water when you were full and have it reduce your food intake because you needed that to offset the seasonal famines and other conditions. And that's really how we evolved and developed on those two preferences. One of the major global issues about sweetness that I'll show from the next slide is we've always loved sweetness, but we have dozens of clinical and random controlled trials that show that what we drink, if it's added sugar, it affects our food intake adversely. If it's plain water, it doesn't affect our food intake, and we don't increase our caloric intake. So water, tea, coffee that are unflavored, no problem. But when you have your chai or your coffee and you add a lot of sugar or other caloric beverages like sweet jams and things, you then enhance your caloric intake by the amount of fat. And just to note, it doesn't matter what form it's in. And I'll show you in the next slide. And since Pakistan's a major consumer of sugar, this is really a big issue. Here you can see if you have watermelon on the right as a regular product, you keep your normal food consumption for the day based on the calories of all the other food. But when you add the watermelon water, when you add coconut milk, which is a high fat milk, or you add protein from milk, you increase your calories by the same amount. Now, if it's a healthy product like milk, no problem. However, when you add sugar to all these products, like we'll be finding increasingly in our beverage supply, then it just adds empty calories. And it's that sugar which has the profound effect on our health that I want to speak about. So we know from actually probably 50 different random controlled trials and large longitudinal cohorts from all regions that when you consume an extra portion of sugary beverages, it reduces quite significantly it increases your risk of all sorts of non-communicable diseases, particularly diabetes and hypertension, which are really major problems in your country, particularly the diabetes. And we also know that there are significant benefits, as I'll show you from Mexico, on dental caries, very quick effects on dental caries, slightly longer to get an impact on diabetes, and 5 or 10 years to really see the major impacts on overweight and obesity. So this is a large literature on this, and we really want people to only consume 5% or more of their sugar beverages. And that's all I'll speak about there. Next, what I want to talk about is taxation and health disparities. In your country, you have a large population that's lower income or wealth, and it has a reasonably high sugary beverage consumption. Now, if we tax the beverages as a percentage of the income, the poor will pay more. However, what we've learned is that in South Asia, across all the low and middle income countries, including my country, the poor have a larger proportion of untreated health conditions like diabetes, hypertension, or if they treat it, it's really poorly treated. And so if we tax that and cut the sugar intake, it's a very progressive tax in impacting those who have untreated diabetes or poorly treated diabetes, and the same for hypertension and all the other non-communicable diseases. So we think of this as a very progressive tax in terms of health. And this slide shows you in Mexico, the lowest income group is at the top, and you can see the much higher impact from the green line compared to the red line for their consumption as if they didn't have a tax, and the green, the consumption with the tax. And you can see the big difference, and it's much smaller for middle and lower income households. So the second is taxation and revenue. And I want to point out that when you tax something based on its volume, based on its 100 milliliters of beverage, let's say, you get more revenue, but you don't get the same impact on reformulation as well as food purchasing that you do for a sugary tax-based tax like they have in the United Kingdom, South Africa, and Thailand. All other countries really base it on volume or price, which essentially is the same impact. And so we're strongly recommending, when possible, doing a sugar content tax. And I'll give reasons why when I give you an example from Mexico and South Africa. One last point, you can see third country from the right. This is the water footprint of a sugar sweetened beverage. And Pakistan is going to suffer increasingly water shortages in the future, and you need to be quite concerned about water supply. And what we know is in Pakistan today, about 275 liters of water are needed to produce 1 liter of a sugary beverage. So you can see the environmental impact also is quite significant for your country. Taxation is the major option that countries have to use to control. There's strong evidence that with a 15 to 25% tax will have a significant impact on sugary beverages. We also have very little evidence that they'll move to other kind of sweeteners and other things, sweet foods. So that it's really, when they see a shift, we're seeing it toward bottled water, if any other beverage that you purchase. And that depends on the income group. The poor might just drink regular water from the tap or from the fountain or wherever it is in the village that they get the water. We have about 45 countries today that have passed SSB tax. The largest are the 50% in the Gulf states, but we're increasingly seeing other countries considering much higher taxes than they initially began with. The World Bank and the IMF are now promoting sugary beverage taxes along with alcohol and tobacco as 3 major sin taxes. Here's some of the countries, and I will point out the Asian countries a little bit more here, and you can always look at these slides later. I don't want to go into detail with them. Most of them are, I think, too small, the tax impact. And I think you need to add a significant tax and remove any subsidies you have on sugar to really make this impactful. So I'm going to compare 2 countries that had a 10% tax, one per 100 liter in Mexico and 1 per gram of sugar as in South Africa. And this is the Mexican. There was a significant decrease in the tax beverages and a significant increase in water purchases. At the same time, after the second year, we got an extra benefit. So while it was only for low-income people a 9% decline in the first year, by the end of the second year, it declined by 14%. And for all income groups, it was an additional benefit. So you need to look at taxes over several years to understand the full impact. One of the more interesting things is, here's the dental caries on the right, the days and weeks after the law was applied. You can see right away, they started to see quite clearly within the first and second months, significant declines already in dental caries for those that were for after the sugary beverage tax was instituted in Mexico. Now, this is a huge sample, and we found for every age group a reduction except 5-year-olds for some strange reason, and maybe the sample size was smaller. Next, I want to speak about the South African Health Promotion Levy. As I noted, it's when all beverages in excess of 4 grams per 100 ml are taxed per gram of sugar. What I'll show is some of the significant impacts of this next. As well, all the countries put in an inflation clause. So this is found in every country. So that's important because you may have significant inflation in your country. The South African tax was about 10%, but sugary beverage consumption declined by 90% in the taxed beverages. The sugar content declined even more because we not only had the tax changing behavior, but we also had the industry cutting significantly the sugar content of all beverages. And we have an example of this with the differential effect on low-income South Africa. So we have a cohort of South Africans that we did 2 cross-sections on in a lower income settlement in a city. So this is a low-income population. We did 1,000 interviews before and 1,000 interviews after. And I will show you on the next slide some of the impact. When you go from the yellow to the green, that's the 6.5 gram impact from behavioral change. But then that's keeping the same food composition that we had in 2018 for the very detailed diet data in 2019. Or I can't remember the exact years, excuse me, but year 1 and after year 1. Before is the baseline and then after. But then when we add in reformulation, we got an additional 2.5 gram reduction. So the net impact, also they did increase in some untaxed beverages. So the beverage intake didn't go down that much because they went to water mainly when they purchased. But they also moved to tap water, which is potable in that city where Lunga is located. So they could easily go to water, and they did. Now, I want to mention one last thing about this, is the impact of sugary sweetened beverages on employment. You'll hear the industry saying it's horrible. It's going to cut our employment. It's going to destroy our industry. But what we found in very detailed studies in Mexico, the United Kingdom, a large city in the US, and Chile was that we found no impact on employment or wages. Even in Chile, when the law had a large impact, 25% decline in SSB purchasing from a different set of laws. So we really have yet to find any country where we've studied carefully employment where there's been a decline, whereas the industry and all the industry-funded groups will say we're going to have a horrible disaster. No example of this. From significant taxes in the UK, in South Africa, Philippines, Mexico, Chile. So in summary, fiscal taxes work. And fiscal policies focused on these taxes are important. The 2 options are sugar content taxes or tiered taxes like the UK put in for quantity of sugar, and they increased the tax as the quantity went up in brackets, or the volume tax like most countries have used. The volume tax produces more revenue. The sugar tax reduces and produces a much higher health impact. I've also shown here that these taxes are progressive as it comes to health, and they reduce health disparities. And that's very important because you have quite large health disparities in Pakistan. And the future lies with a meaningful SSB tax for Pakistan as a first step to addressing your NCD problem. It's the quickest and easiest way you'll see impacts on many of your health problems. Now I want to mention very briefly before I end about Chile's warning label. It's been used for a multiple set of policies. They created a nutrition profile model which identified about the top half of the food supply, which was truly unhealthy, very high in added sugar, added sodium, added saturated fat, and if it was high in any added of any of those, also in energy density. If it had any added sugar, fat, or saturated fat. In your country, you might also use trans fats if it's not really controlled and have a warning label on that as well. When it has anything more than, let's say, a half a gram of trans fat for 100 grams, or whatever you want to make your cutoff. Some countries use the warning label for any trans fats in the product. And they also use it for a marketing ban. They use it for a school ban, not allowing these school foods to be marketed or sold in the school or around the school. And they've also, and India's considering it today, the Food Standard Agency has put out a draft consultation for warning labels. And the World Bank recommends a set of policies because you can use it for a tax to identify the high sugary beverages, the tax, but you can also use it for these other policies and they can be mutually reinforcing. And that's really important because the whole is bigger than each item, as research has shown in Chile and some references noted here in my slides. And with that, I really want to thank you for inviting me here to do this presentation. Remember, we are what we drink as well as what we eat, and they're separate, so we must drink more water and unsweetened beverages and stop consuming the sugary beverages, which represent well over half the sugar content consumed in your country. Thank you very much. Bye-bye. Hi, I'm pleased today to present.
Very impressive. This is how effective plans are enforced and outcomes are for you to see over there. Now that was flavoring of the sample that's about to come in the scientific sessions. But we are getting back to the formal inaugural ceremony where now it's about time for our chief host and president of PANAH. Sir, I'll just take 1 minute in introducing you because people know you for your commitment. Major Masud Rahman Kiani, Halal Imtaz Military, Star Imtiaz Tamgai Basalat. He is the president of the Pakistan National Heart Association and chairman of PANAH Trust and a pioneer member of PANAH for the last 4 decades. He is director and a cardiac surgeon at the Hearts International Hospital, Rawalpindi, and he has had the honor of being in the past the commandant of AFIC at IST, honorary surgeon for the President of Pakistan. He has been a president of the Pakistan Cardiac Society, president of Association for Cardiothoracic and Vascular Surgeons of Pakistan, professor of cardiac surgery, and vice president of College of Physicians and Surgeons of Pakistan, as well as vice president for SAG Cardiac Society. So with the number of publications and the number of mentals that he has, and the number of caps that he has been wearing and still wearing at a very young, but I would say a tender age in the early 80s, he is still playing golf, and that to about 3 a.m. in the morning. And he says he dreams a lot, although I don't think that he has time for dreaming, but maybe he daydreams. And he's fond of reading. That's what he has said. But what I would like to tell you that he is a very good writer. His autobiography, Kayani Kahani, is a treat to read. And I think he will be, as always, a treat to listen as well when I invite him for his presidential address as President of Pakistan National Heart Association, Major General Masud Rahman Kiani, sir.
Thank you very much, Professor Shakil. Bismillahirrahmanirrahim. Nahmadu wa nusalli ala rasulil kareem. Alhamdulillahi rabbil alameen. Worthy Chief Guest, Lieutenant General Nigar Johar, Hilal Imtiaz Military, Surgeon General Pakistan Army and DGMSIS, Lieutenant General Azhar Rashid, Principal Islamic International Medical College and the former Surgeon General of Pakistan Army, General Kamal Akbar, former Surgeon General of Pakistan Army, General Burhan Tayyab, Commandant of Armed Forces Institute of Cardiology, National Institute of Heart Diseases, General Mohammad Ashraf Khan, Dr. Qayyum Awan, Dr. Shahzad, who is Vice Chancellor of the Health Services Academy, Mrs. Dr. Shamim Sarfraz, Dr. Samra, academicians, participants and speakers of the conference, ladies and gentlemen, Assalamu alaikum. The subject of this conference, the non-communicable diseases, is a very important and pertinent one. We have heard about the Pakistan National Heart Association's contribution towards advocacy and other services for prevention of cardiovascular diseases. Since its inception, we are busy in public education and advocacy for prevention of cardiovascular diseases, and it is a number one killer, not only in Pakistan, but in whole of the world. And to a great extent, it's preventable. It is a major part of the metabolic syndrome and also a major part of the non-communicable diseases. We have heard about the devastating effects of the increase of the non-communication diseases in our country and its impact on our well-being, on our national health services, and on our revenues. We don't really realize it. I may state, you have heard a lot of statistics, and I'm not going to burden you with any more, but a few things really are notable. Every 2 or 3 minutes, a person dies of heart attack in Pakistan. And the total yearly figure comes up to 150,000 deaths due to heart attacks in Pakistan. Every day, 2,200 people die of COVID-related diseases in Pakistan. It's a huge figure. It's a huge loss to the society. We have been running a campaign for prevention of cardiac diseases and control of its risk factors for over 3.5 decades now. And we have learned now that the risk factors pertaining to the cardiovascular diseases also are very pertinent to the non-communicable diseases. Therefore, we decided to expand our portfolio to this area as well. We have learned a lot of lessons over these times, and I'm not going to give you a formal speech, which I have with me, but I'm going to speak to you from my heart and give you certain lessons that we have learned over the years, the difficulties we have faced during our campaigns, and then we'll probably uh, like to come up during this conference some ways and means of tackling those difficulties which we have faced, so that we can formalize, we can modify our policies, our strategies for the future benefit of our nation. Recently, our main thirst of our campaign was for two major risk factors. And these risk factors, as you've heard, one of them in a very great detail from a foreign speaker, that is the sugary sweetened drinks. And that risk factor doesn't pertain to drinks only, it also pertains to the sweetened food stuff available to us in the market, especially with highly refined carbohydrates and preserved food material available over the counter. And also the flourishing shops of sweets and halwajats in our country, where we are very fond of sweets. And we are a lazy nation, we are not fond of any physical exercise. Now, during our campaign against the tobacco, and it was triggered by the so-called third tier of taxation on cigarettes, which was imposed a few years back by the government. I don't know for what reason. They gave us reasons, but they were absolutely not convincing. The result was that in a few or 1 or 2 years, we lost billions of rupees in tax revenues from the cigarette producing companies. There was a great increase in the consumptions of the cigarettes because they were cheaper and easily available to the general public, as evidenced by the overproduction of the cigarettes legally, and an illicit production of cigarettes was also going on at a great stage. We went from pillar to post to all echelons of various policy making, legislating, and implementing authorities. We also went to the courts, higher courts, for Haki Motsib, and after a few years, that taxation was waived off, but not before a lot of loss, a lot of misery, and a lot of increase in the mortality and morbidity due to diseases related to the tobacco use. Haki Motsib had decreed that the agency was negligent and it was a maladministration on the part of the agency according to certain rule and act, which was enacted in 1983 in Pakistan. And it advised the government agencies to comply with the WHO Convention for Tobacco Control, for which Pakistan is a signatory. And it requires that we increase taxes on the cigarettes every year so that gradually the cigarettes are so difficult to purchase for the general public. And as you have seen, such type of interventions are one of single major factor in reduction of the use of the cigarettes by general public and also by sugary sweetened drinks, and their positive impact on spread and increase in NCDs. You have heard. We have been working with the central government Department of Health, Ministry of Health, and Coordination Regulation. And Dr. Samra is here and she is a witness to it. And we have found that this ministry was very helpful to us and they listened to us. But their advices and their letters to the Ministry of Finance and other relevant agencies were probably lost in the bureaucratic rigmarole. The latest one is the recommendation by Dr. Faisal Sultan to the Ministry of Finance, which was forwarded late last year, that a health levy, it was a small amount, not a very big taxation on sugary sweetened drinks and cigarette. It should be imposed on these two items. And again, that recommendation got lost in the bureaucratic rigmarole. What's happening? We are up against, ladies and gentlemen, very big and influential agencies, industries, and I won't like to use the word which is very commonly being used for such people these days, both in politics and in the industrial era. They are so influential with their unlimited resources. They can produce, I would say, very fake research papers, research products, and bring out the statistics of their own. And for certain agencies, they are so compelling as compared to the statistics of the scientists and the workers, sincere workers in the medical profession and science, that they bow towards the industry rather than to the science. The result is that death, disability, and misery due to COVID, due to NCDs is increasing as the time passes on. You have heard that we had presented to the President of Pakistan the National Health Preventive Health Initiative, and Minister of Health, Federal Minister of Health and Coordination and Regulation is also present in those meetings in the presidency. But again, that a comprehensive document and concept paper, we think is a lost in bureaucratic rigmarole. We need to redouble our efforts, and the main theme of this conference, ladies and gentlemen, is we do not deny that one of the major tools in prevention of all type of diseases is public education and advocacy. But the main thirst of this conference, we believe, is to develop policies rules, regulations, and formulate interventions so that we can tackle this menace. And this can only be done if we get together all stakeholders in this area. And the stakeholders are representatives of some of these stakeholders are sitting here, and also the Ministry of Finance, Planning, the Health, FBR, and overall our elected representatives. On the other hand, there are people, there are professional medical associations like Pakistan Cardiac Society, Pakistan Society for Diabetes, Society looking into the cancer and related diseases, hypertension, and you name it. They have frequent national and international meetings. They develop their recommendations and findings, and they present it in the conference. And some of those findings and recommendations, I believe, are forwarded to the relevant government agencies as well. But there is a lack of confidence between these two types of stakeholders. You see, people working in the offices, in the great echelons of the government, in the drawing rooms, dealing with files and computers, are a different type of people. You know, the files do not have diseases, they do not suffer injury, they do not die, they do not suffer disabilities and pain. Once you finish in the afternoon, you close the file, and go home and have a peaceful afternoon, night, and peaceful sleep. On the other hand, people dealing with the general public in the form of social workers, doctors, paramedical staff, and like people who deal with these miseries every day. They deal with the relatives of the patients who have just died. They listen to them. They have to share their feelings. And I assure you, a portion of that surgeon or physician dies with the dying patient for the time being. They go back home and they get nightmares. They don't have a peaceful night's sleep. Apart from that, the pain and the suffering of the people in the hospitals and the clinics and on the streets, in the houses. Somebody has to go there and then feel it. If we get together, if we tune up in the same wavelength, these two types of the stakeholders, develop confidence in each other, and devise methods and mechanisms for expert exchange of knowledge and database, we might be able to make good policies and interventional tools for the future. There are a lot of factors responsible for progression of the NCTs, and each factor needs a separate group of experts. And these experts should be from both types of the stakeholders. They should sit together there should be a permanent platform on which these stakeholders sit and not only devise the policies for once only, but go on meeting in the future and go on revising the policies and the intervention after getting the feedback and statistics and data, so that we can see the effectiveness of our measures which we adopt. There's no use making a policy and forgetting about it and leave it for the people to follow blindly. Our people need perpetual reminders to adhere to the drill for prevention of any type of diseases. Now, Pakistan National Heart Association is also devising and revising its policies and its recommendations for certain things. The menace of adulterated food. There's no rules and regulation and policies for any detrimental punishments or methodology to curb this menace. All types of food are adulterated. Maybe fruits, may it be vegetables, grains, condiments. The besan we use for pakoras and samosas, the oil we use to fry these things in, I don't know. Then we are talking of sugary sweetened drinks, both branded and unbranded. The market is full of it. But there's a bigger menace. The bigger menace is the spurious factories are being run in the garages of the people. Spurious drinks are being manufactured in which there's not a drop of natural juice. The only essence and industrial colors on those there. And those industrial colors play havoc with the health of the people and children. There's a hell of a lot of sugar in it. WHO was alive to this situation many decades ago when it formulated its recommendation that only 50 grams of sugar are enough for an adult for a day, and more than that it becomes pure white sweet poison. It was about to release those recommendations for the general public. The Secretary Industries of America rushed to Geneva and threatened WHO for stopping its funds if these recommendations were released. It's well documented fact. So the industries of fat extracted prepared food flourished, and the industries with sugary sweetened food material and drinks flourished. There's hardly a mile of high street anywhere in the world in bigger cities in which there are not more than a dozen advertisements for sweetened beverages and food material. And there used to be very hilarious advertisements for cigarettes at one time, that you can have a cigarette and then jump up to K2. And now these days, those days are gone, thanks to the efforts of some of the stalwarts of Pakistan National Heart Association like Dr. Qayyum Awan, with the help of the then Secretary Health Sadiq Saeed. We were able to control those advertisements and initial policies were made to curb the cigarette advertisements, and other policies were made. But such things are not there for the sugar sweetened drinks. You can have a drink, you can not only charge your own batteries, but you can charge the batteries of a sweetheart's car, and you can jump up to K2 and beyond after having a drink. So such rules and regulations need to be made to stop such type of things. And you have seen, you have heard that interventions and taxes in such matters brings short-term and long-term results. There need to be school health services, which are non-existent in our country, in which we should teach them at various levels, schools, colleges, and universities, the preventive hygiene and health measures and the first aid, including CBR. There are no effective preventive health departments in any medical health institution, teaching institution. There are no preventive health departments in big hospitals, maybe specialized or general. It's a non-lucrative profession. We have to make this profession more lucrative and incentive-driven in the past, if we want to look after the health of our future generations. There need to be cooperation between various organizations dealing with the public health. I'm so pleased that one of such cooperation exists between Pakistan National Heart Association and Armed Forces Institute of Cardiology, which is parent organization. And a new institute is in the offing, which is, I believe, will be known as National Institute of Heart Diseases, Center for Excellence in Prevention and Research in Cardiovascular Diseases and Development. I believe it's known as NEPCARD. The blueprints are ready. The site is allocated. Fiscal and codal formalities need to be completed in the near future, and I hope with the efforts of the Commandant of AFIC and the Surgeon General, it will materialize soon. Such cooperative ventures, and this is another example of civil-military cooperation for betterment of the health of the nation. Ladies and gentlemen, I'll stop here. And before I go, I must thank the Pakistan Science Foundation for solely sponsoring this organization. I've expressed my gratitude to Islamic International Medical College, General Azhar Rashid, who is also the chairman of our organizing committee, being the host of this conference and affording us all the logistic and administrative facilities, including the IT facilities, so that this thing is being presented all over the world on the social media. Mary Maqsood, the vice principal, has worked very hard, night and day, with his staff to make this conference a success. I also thank profoundly the brain behind the conference, our chief scientific advisor and chairman of the scientific committee, Professor Wajid Ali, and his co-chairman, Dr. Shakil Mirza, for their valiant efforts and hard work put in to make this conference a success in a very short period. Dr. Munawar is to be complimented for his effort as well. But last but not the least, this conference would not have been possible without the valiant and passionate efforts of our General Secretary, Mr. Sanaullah Gumman, our single man army. Thank you very much, ladies and gentlemen, for bearing with me. Good office.
Thank you very much, sir. And now, ladies and gentlemen, a very personal moment of pride, in fact, sublime pleasure, in introducing our chief guest, Lieutenant General Nigar Johar, Halal-e-Imtiaz Military, Surgeon General, Director General Medical Services, Inter-Services at General Headquarters, Rawalpindi. You all know she is the first 3-star female general in the history of Pakistan. And when she was given on the 3rd star, she was the only female general who was who was commanding a corps at that point in the whole world, which very few people know. What I cherish, that she graduated from the 5th batch of the Army Medical College in 1985, something that both of us share. And as in college, she has excelled in everything that she was entrusted with as a commissioned officer. In academics, she acquired the degrees of member of College of Physicians and Surgeons in Family Medicine. She had a degree of MSc Advanced Medical Administration, to be followed by a Master's in Public Health from our Armed Forces Postgraduate Medical Institute. You all know she has made history. She has made history in breaking the glass ceilings repeatedly and consistently by becoming the first female commandant of a Class A hospital. No other lady had that as a brigadier. And then the first female commandant of Pakistan's largest military hospital, the Pak Emirates Military Hospital, Rawalpindi. Another feather in her cap was becoming the first Mcolian to be the vice principal of their alma mater, the Army Medical College, of which we are really proud, madam. As the Surgeon General of the Pakistan Army, she has pioneered new programs, restructured the health services delivery, and given impetus to the capacity building and the skill development of doctors, nurses, and paramedics in a way which has been unparalleled in the history of the Army Medical Corps, and for this she needs a big applause. Ladies and gentlemen, I request the chief guest to address this august house, the Surgeon General.
Thank you, Professor Shakil, for the very kind words. Major General Masood Rahman Kiani, Halal-e-Imtiaz Military, Sitara Tamgha Bisalat, President PANAH, and Lieutenant General Azhar Rashid, Lieutenant General Kamal Akbar, my Senior Generals, and we have Dr. Shahzad, who is my supervisor of MPH here, and then Dr. Qayyum, Dr. Shabnam Sarfaraz, who is a friend and a member of Planning Commission, Dr. Samra from Ministry of Health, General Ashraf, one of my mentors, and General Farhan Tayyib, Commandant AFIC, General Wasim, august audience, ladies and gentlemen, Assalamu alaikum. Thank you very much for having me here, and it is a privilege indeed and an honor to be standing here on the podium of PANAH, because I am associated with this for the last 3.5 decades when it was established. It was established by General Zulfikar Ali Khan then when I was a young captain at AFIC, and since then I'm seeing PANAH and I'm seeing it growing. So PANAH was created as a platform for preventive health care, especially in coronary artery diseases. But I feel that it is rightly said, as General Kiani has said, that the scope has been widened to include the non-communicable diseases. And as Professor Shakil said, that this is a huge burden, and this huge burden is on our healthcare and on our country and on the individuals, and it has its impacts, and especially the financial impact that it carries with it, and we have to do something about it. And as already General Kiani said, that there's a death from the coronary artery disease, which a huge chunk of the NCDs every 2 to 3 minutes. And globally, more than 40 million deaths occur annually because of this. So, and the rate is increasing, and the mortality and morbidity associated with the NCDs is also increasing. So this is the right forum and the right way to tackle this. And PANAH was initially established or created for this purpose. But the PANAH has gone beyond the original scope of just making the public aware. That it is doing much more than that. So it is creating the public awareness, but at the same time, it is also creating ripples at the national political landscape. And the examples, and it has also gone into policy making and regulation implementations and devising regulations, which is so essential. And the success story, one of the success story, huge, is the tobacco taxation, as already explained by General Kiani. And I feel that maybe in the future, as he said that he have already created a preventive health initiatives, and they have gone to a certain level, although they are stopped somewhere. But I'm very hopeful that when the things are started, when the initiatives are rolled, ultimately they do happen. So I'm hopeful that they will have their fruits, and I am also hopeful that we will have certain taxations that are required for the white poisons, as said by Professor Shakil, and especially on taxation on sugary drinks to start with. And maybe the time would come that we will have that also. So we need to have policies, and we need to initiate certain rules and regulations, and then that will happen. And I totally agree with all the recommendations that are there. And I as a Senator General of Pakistan Army, will be always there, and I do support PANAH in all the initiatives and all the work. So I would be making difference wherever I can. And as you said, that there are no preventive areas or departments in the healthcare hospitals and the setups. But we are coming up with one such PANAH is there for the last 3.5 years, the 3.5 decades. And then we are coming up with NAPCARD. So NAPCARD is another initiative which will be working for the prevention, and it would be the first of its kind in the country. And I know when it is there, it will be doing a huge work. And then seeing this, probably we will have more in the medical setups. And there is always a start, and this would be a pioneer institute. So similarly, I also feel that there are things that are coming up. For example, NIH has been restructured, and there are so many things have been added in the National Institute of Health, which includes Institute of Nutrition and Health. So nutrition and health will again look after those nutrition aspects that we want to, because as you said, that the non-communicable diseases have a lot of risk factors, but fortunately, majority of the risk factors are modifiable, and they are preventable, and they are controllable. So there would be a time that we be focusing one by one, and there would difference would come. So already the certain things are visible on the screen, and I feel that much more has to be done, as said by General Kiani, and much more rules and regulations are also needed, and policy making is also needed. But this conference itself is a testimony that we are focused towards it, and I am hopeful we will be doing it. But last but not the least, let me express my gratitude to all the organizers of the conference, and my gratitude to General Kiani and his team, and especially the gratitude is to the audience that is here on a Saturday morning on a close holiday for a cause. So that shows your motivation. Thank you all. Pakistan Zindabad, our medical corps Paindabad.
Before we close this ceremony, we'll have a small presentation ceremony for the souvenir for the chief guest. May I request Mr. Goman to come up on the stage, please. With this, we come to the close of this inaugural session. We are a little bit short of time, and I would request that when the chief guest departs, we follow her for the tea break and come back here in 15 minutes time